How do we know?
He'll tell. Chaital will tell, sir. Chaital
We
will tell.
won't be able to see here, right? Because I cannot see anything here.
Yes, sir. We are in live. Sir, we are in live. Good to go.
Yeah, cannot see anything here.
Sir, here only we will be available. So the viewers, in the viewers link, everybody can see you there, sir.
Okay, I know, but if somebody has joined, we cannot see
Hello,
here.
sir.
So this is the
Chinmay,
panelist
sir.
link.
Right. Okay. Got it. No.
Chinmay, sir.
So yeah, we are live, sir. You can
Sir,
start.
we are.
Can you suggest how many are joined, please? Mr. Chaital? Hello, this is for information for all the participants who are just
69,
logged
sir.
in.
Yes, yes, sir. Only
They've all joined, is it? They've all
Yeah,
joined.
yeah, 69 have
So now
already
we are
joined.
in 69. Yeah.
Okay, right.
Yes.
Okay,
And
this
then
is
we are in live. Good to go. Yeah.
okay. Good evening, everyone. For those of you who don't know me, my name is Vijay Harbi Shettar, and I'm one of the psychiatrists working in Bangalore and one of the coordinators for this Telearogya webinar series. And today we have an interesting session. In this Telearogya webinar series, we have today a discussion on Quetiapine. To begin with a disclaimer that I don't have any shares in any of the Quetiapine company. This is a product which is this is a molecule which is very important, especially for elderly and where we have some worries about side effects and things, tolerability issues and other things. So we thought this is an interesting discussion where we learn about different properties of this molecule. We can revisit this because there have been new updates as well. So let me introduce our moderator. Unfortunately, Dr. Jagdish is not available due to some personal urgent commitment that he got at the last minute. But he said he will try to join in the middle at some point. To fill in his shoes, you cannot expect any better than Dr. Mahesh, who is again a multitasker and he needs no introduction. He's a Superman. He's a troubleshooter. He runs the Spandana 2 units very actively, sees about 100 odd patients every day, and he's up to date and he knows all the, he's been a past president of IPS KC, and currently he has been elected as the editor, honorary editor of the Indian Association of Private Psychiatry. I don't think you need any more introduction about Dr. Mahesh. He needs no introduction basically. So let me advise you that you can put your questions in the Q&A box, which will be picked up, or via the link that has been sent to you, which will be picked up by Dr. Mahesh when he is moderating the session. Welcome you all once again. Hope you have an enjoyable and learning evening. Over to you, Dr. Mahesh.
Thank you, Vijay, for this wonderful introduction. I think this is the first of its kind to be introduced this way. A lot of other things used to be talked about. I think you talked about totally the parallel part of me, which you described me today. Thank you for the introduction, Vijay. I think today is going to be interesting. We had to discuss about Quetiapine, and we've known this molecule for so long. We have a lot of trust in this molecule. We know it works in so many indications, and a lot of people believe that it's an all-rounder molecule. And to watch for this molecule and to discuss about how effective it has been over the last decade plus, we have three important panelists today. The three important panelists I would like to introduce in order. I thought first I'll introduce the lady of the group here, Dr. Supriya Hegde. She is the professor and HOD of the Department of Psychiatry at Father Muller's Medical College, Bangalore. She also consults at a private polyclinic. Her interests have been women and child health and adolescence. She's been very active member in IPS KC also, and she's been a popular face in the last few seminars and webinars has been happening, and she's quite active. Welcome, Dr. Supriya. You're muted.
Thank you, Dr. Mahesh.
Okay. The next in the panel is Dr. Alok Ganate. He's the professor and HOD of the Department of Psychiatry at MRMC Gulbarga. He has also been very active with IPS KC. He's also been one of the pioneers in conducting tournaments in IPS KC Premier Leagues. And Dr. Alok runs his own hospital. He actually has a lot of fond interest in de-addiction, rehabilitation, and inpatient services. Welcome, Dr. Alok.
Thank you, sir.
Thanks for joining us, Alok. The last would be Dr. Vinod. He's a good friend of mine. We work together. We've been colleagues. Right now, Dr. Vinod has graduated, and he actually heads the department at. Just a minute. I'll just pull out all his degrees so that I don't miss anything. Actually heads Empower Bangalore. He's been a consultant psychiatrist. He's been very strong at his psychotherapeutic skills. He's had a lot of training and certification. Other than his MRCP and CCST, he's also a certified psychodynamic interpersonal therapist. He also does a lot of work in CBT, and he's a certified group analyst. Apart from being psychodynamically and psychotherapeutically oriented, Dr. Vinod has special interest in psychopharmacology. He's actually worked with us. He's seen how the Indian scenario is. Before he came to India, he's actually worked for 13 years plus in UK, and then he moved here to test waters in India. Welcome, Dr. Vinod.
Thank you, Mahesh.
Just to make sure this webinar is not going to be very monotonous and didactic, I thought we should keep it just as a panel discussion. So we don't have any PPTs today. A lot of questions have already come in, and I'm going to put some questions to the panel in the reverse order now. I thought I could check with Dr. Vinod on a few things. Dr. Vinod generally sees a lot of patients in adolescents, and he's actually doing a lot of work on ADHD. So I thought I'll first check with you about your experience of use of quetiapine in children and ADHD. Over to you, Vinod.
So, not so much in children, Mahesh. It maybe older adolescents. So, kids above 15 have had some experience, but again, very low doses. Particularly if there is any concern I have about potential for hyperprolactinemia, if there is any concern in terms of weight gain even, and if I need sedation, at night, I would go very low dose, half of 25 and then build it up from there. But not a great deal of experience. I would say, maybe 2 or 3 dozen patients, and generally good experience. So even 12.5 sometimes. Just today, I was talking to this young 18-year-old girl, and she was on 12.5. Good response to kind of an add-on therapy for escitalopram and all that, but she would still wake up feeling a bit groggy. So I kind of asked her to stop it for the next couple of weeks and see, because that seems to be the only concern with this molecule. And for some reason, I find that compared to white Caucasian people, our people are extremely sensitive to sedation. This molecule causes, because I've known every time I go back to UK for a locum, almost general adult OPD, 50% of the people are on quetiapine for one indication or the other, and they all love it. And they're walking around happily with 800 even. 600 is a normal dose there, and here we're messing about with 25, 50, 100. So I think there is a kind of very clear difference in the way our body handles it as Indians. So I think it's very useful adjunct in ADHD, Mahesh. I would say there is some evidence, and I've had a very good sort of success with it. So a lot of kids would say, I put them on Concerta. Kids in the sense, 16, 17, 18-year-old, and the only issue would be the problem with sleep or sleep initiation. So a low dose of quetiapine to go with it will solve that problem, and also kind of counteract the appetite suppressant effect. So it's a very good combination. There's some evidence base for that working as well. Not as a routine, of course, just to counteract that. And also if you're thinking about comorbidity in ADHD kids of aggression and getting violent with the parents and so on, so it's a useful kind of molecule to consider, I think.
Thank you, Vinod. I thought I'd just add one more question. Do you actually see a difference in the way prescription of quetiapine has been there in UK versus Indian scenario?
Yeah, big time difference. So there is no such thing as 25 mg there. We normally start on 50, and the dosage are very rapidly escalated. So people think, see, one of the kind of reasons why the molecule did not take off that well as an antipsychotic to begin with when he first came out, a long time ago now, was initially the sustained release business was not there. It was in UK, at least, it was only available as a BD dosage molecule. And if you gave any effective dosage, people would be very sedated with it. So it really then there was a big block. And then when they came out with the sustained release version, that's when it really started getting its traction. And over the years, it's changed. But in UK, clearly the dosages are huge, and the usage primarily for borderline personality disorder. And see, the thing is, there's a lot of medical legal constraints there, unlike we have here. So to prescribe antipsychotics for personality disorders or for intractable anxiety disorders is very difficult to justify there, So, but quetiapine you can justify, or quetiapine you can justify because it has got license as an add-on therapy for depression, So psychiatrists in UK have always been prescribing low-dose antipsychotics out of license, for anxiety, like we all do. But quetiapine has got this sort of special entry into that field. There's a legal kind of entry. So huge amounts of prescriptions. I mean, I think it's unbelievable. And the dosage is, if not 3 times, at least 2 times on an average from the Indian prescription. I would say 3 times. So they're very happily taking 600, 700, 800, no problem. I really see those sort of numbers here,
Suppose we assume that the metabolism and related parameters in India and UK are similar. Are you trying to infer that the severity of the symptom or the psychotic presentation in UK and India are different?
No, I think my only inference is probably not, but I think there's a lot more personality disorder there, no doubt about it, for whatever socio-cultural reasons. But what I would infer is the way our body handles. For everything is the same, isn't it, Mahesh? So in Europe they do not even market metazapine 7.5, for instance, and we all start at 7.5, isn't it? It's unheard of there. It's the same with almost all the molecules. I think we need lower doses as you go east, perhaps even lower when you reach Japan and countries like that. I don't know, but there is a bit of sort of literature on this. It's about the sort of genetics of metabolism and so on.
Okay, thank you, Vinod. Over to Dr. Alok. I thought Alok could talk about the various indications in which quetiapine has been actually preferred. Firstly, I thought Dr. Alok could talk on role of quetiapine and when actually this sort of molecule could be chosen in a case of psychosis. You have so many drugs, but why quetiapine in a case of psychosis?
First of all, quetiapine, mainly it has been indicated by FDA for more than 13 years of age in acute treatment of schizophrenia and even in maintenance treatment of schizophrenia. The dosing of quetiapine in psychosis is quite different. It has to be more than 300 mg. The FDA approves for 400 to 800 mg of quetiapine for psychosis treatment. Off-label use of this molecule for other psychotic disorders like Parkinson-induced psychosis, and along with the levodopa-carbidopa combination psychosis. And we find in our clinical practice that we add on quetiapine as an augmenting agent along with the other antipsychotic drugs like risperidone or even haloperidol or something like that for the efficacy in terms of sedation. Coming to the symptom parameters of the psychosis, it has been found equally effective in terms of positive and negative symptoms as comparable to haloperidol. But clinically, if we use it, it is found to be less effective than olanzapine and risperidone in positive symptoms of psychosis. About the cognitive symptoms, it is found to be helpful by increasing the prefrontal cortex dopamine level by blocking alpha-2 receptors, by helping in terms of executive functions in few of the patients. Obviously, quetiapine is benefited in terms of mood symptoms also.
Suppose you have 5 or 6 antipsychotics. When would you actually pick up this molecule to be prescribed for a case which has a psychotic presentation?
I would like to prefer this molecule if the positive symptoms are not that significantly high, or even though the positive symptoms are significantly agitation and restlessness is very significantly high. The sleep is not commonly seen in these people. The sedation is a part which we need to look at with this molecule. And the dosing pattern which has been prescribed over here is around 25 milligrams in day 1, then 50 BD on day 2, and slowly escalated on day 4, almost 400 mg. Most of the antipsychotics which we have, like haloperidol, or even atypical antipsychotics like risperidone or amisulpride, olanzapine as comparable, this drug is not that much, this drug causes more of sedation, which helps in calming down the patient. One thing is we need to know that it doesn't have any EPS potential. The acceptable symptoms are very low. It is found to be as comparable to clozapine as compared to other antipsychotics.
That's good news for us. How about role of quetiapine in bipolar disorders?
Coming to the bipolar disorder, FDA has approved as an indication for acute mania in more than 10 years of age as a monotherapy or even adjuvant to lithium and valproate. Even in maintenance of the treatment, maintenance treatment, quetiapine is considered to be one of the good drug to be used. In acute mania, the dosage range from 400 to 800 mg. Agitation is an issue where sleep is an issue. At that time, we can straight away start with 100 mg OD of quetiapine, and slowly on a day wise, day 2 200, then 300, and on day 4 400 mg we can reach. And it is beneficial in these patients. About bipolar depression, both type 1 and type 2 form of depression, bipolar type 1 and type 2, it is found to be very much beneficial as an adjuvant or as a monotherapy. Especially, it has an advantage that it doesn't cause any switch. If you use any antidepressants for bipolar depression, chances of switch is very high. One thing we need to understand over here in bipolar depression, the dosage of quetiapine which is used is around 300 mg. Beyond that, it is not found to be that much beneficial.
That's nice to know that it can be quite useful with bipolar. Thank you, Dr. Alok. Over to Dr. Supriya. I actually forgot to mention, other than the gold that she's bought and carried, she's also a gold medalist from MAHE. That's an additional qualification from MAHE when she passed out during her post-graduation. So the next question I thought I should check with her is, since her interest has always been woman, child, and children with adolescents, I thought how safe is quetiapine as a molecule during pregnancy and lactation?
Dr. Mahesh, clinically speaking, we have given quetiapine to a lot of pregnant women who came to us sometimes in the first trimester, sometimes in the second trimester also. So we ended up actually tapering down the mood stabilizer and increasing the dose of quetiapine. So if you look at the, obviously there is no FDA approval for this kind of thing, but there is no like proven teratogenicity of this drug, in the sense that this definitely causes this anomaly, that thing is not there. And these problems of what a woman with untreated schizophrenia or untreated bipolar, the problems that are associated with the pregnancy and the looking after of the child when it's born, far outweighs the risks that are carried by quetiapine when it's given during pregnancy. But if you look at the literature, it always says it's always a risk-benefit ratio. So you look at the risks, you look at the benefits, and then you can give. I was reading of some animal studies data also. So they have studied quetiapine at doses more than 800 milligrams in rats and rabbits. So in that, there is some problem in osteogenesis and things like that. But then there's no human literature as such, which I could go through. Clinically, also, when in the cases that I have treated with quetiapine during pregnancy, they have had a smooth pregnancy. Lucky for them and me. And even post delivery, we normally don't ask these small details. Whether the child was having any extrapyramidal symptoms at the time of birth, or there was hypertonia or hypotonia, or increased irritability in the time of withdrawal. These are the small things which may actually be missed because we don't really clinically ask, but literature says that these things can happen when there is a lactating woman who is on quetiapine. But overall, they say it's a very safe drug. We haven't had any major problems. But if you go through individual case reports, some things like sudden infant death and these things are also cited. But clinically, I have not experienced, God forbid, I haven't experienced, don't want to also, of these things. It's a relatively a safe, one of the safer antipsychotics.
Nice to know that it can be used in this sort of special population. How about the other extreme, looking at elderly population? How comfortable are you to prescribe quetiapine as a molecule for an elderly population?
There is a FDA black box warning against prescribing antipsychotics and even quetiapine in elderly patients with dementia. But clinically speaking, quetiapine is a wonder drug. It doesn't cause much of EPS. The elderly population is already compromised in terms of their movements and the proneness to develop extrapyramidal symptoms. So clinically very efficacious, but not at a dose of 800. Start at 25, slowly build it up, maybe half of 25. And most of them at 100 would do well. But if they are hepatically or renally compromised, then the dose has to be slashed to 50%. Because giving a higher dose brings forth the risk of delirium, brings forth the risk of falls, metabolic disturbances, further worsening of the metabolic parameters.
So are you trying to say that it's not contraindicated when you cut down the doses during renal and hepatic impairment?
There is no absolute contraindication as such, but if there is an impairment, then you start low and go slow and give the lowest effective dose possible.
Thank you, Supriya. Dr. Vinod, I'm back to you again. Since your interest has been always, you have to unmute yourself, Vinod. Since your interest has always been personality disorder, access to comorbidities, have you preferred this molecule with people with access to typically borderline personality disorders?
In UK, yes. But I think, my experience with Indian population with quetiapine generally is that the sedation part becomes a problem, more often than not, at least in my kind of clientele. So, what they kind of myths they hold is that with your medications, you psychiatrists, you make us like zombies and sleepy-headed or fat, right? So now my endeavor always is to kind of give them the reassurance that my medications, what I'm prescribing, will do none of that, So with that in mind, my go-to drug in recent times has been loracidone, just 20 mg of it, low dose and it works wonders when it comes to impulsivity and anger and aggression and so on in a borderline person or kind of mixed personality sort of person as well. So a low dose antipsychotic is it really sort of is essential in the severe end of the spectrum of borderline people. So I mean, because of the sedation, my use is limited. But there are times when we need sedation. So if insomnia and sleep disturbance is an issue, then a low dose I have tried on a few occasions, and it works there for sure. But in UK, prescribing risperidone or loracidone or any other antipsychotic for somebody with a primary diagnosis of borderline personality disorder is kind of difficult. I mean, people do it all the time, but it's off label and all the rest of it. But like I said earlier, quetiapine gets a way in because of its. You say that this person also had a depressive episode, and the antidepressant alone is not enough. So you're adding quetiapine as a way of augmenting. It's got the sort of approval as an add-on therapy for depression. So it comes in that way. But also a lot of usage for anxiolytic effect, so in a general little setup we see a lot more neurotic people than psychotic people, and that's the kind of I think the kind of fate of quetiapine is that it's more for the neurotic spectrum utility than psychotic spectrum, because to get antipsychotic efficacy like other molecules you need to like prescribe high doses like Dr. Ganati was saying earlier. And in my experience, that's very seldom tolerated by people, because if you zombify them, then the US FDA doses. No way, I don't think it works very well. I'm sure there are people who tolerate it, but not majority in our setup, I think. But quetiapine usage is really. I'm not exaggerating when I'm saying it's huge in UK. Uh, I don't know if there has been any kind of audit or study of it, but it's almost like a certainty, like how in India escitalopram is a certainty in any sort of psychiatric prescription. It's that kind of a molecule there, almost everybody's on it, and the conversations are usually about, doc, I want to increase the dosage, so if they're on 600, they are like mongering for like a bit more and so on, so that's the kind of. But then I take an 8-hour flight back, and it's a different ball game. Then I have to deal with like very different kind of set of people and demands. I think.
Vinod, I thought I'll just check with you, since you're talking so much about why people don't like it. What is the commonest reasons why people discontinue quetiapine in UK or in India?
I think sedation has to be the most important, the only kind of chink in its armor, if you like. So if you go by sort of the potentiality for hyperprolactinemia or EPSCs or for weight gain, it's relatively better, obviously. But sedation is where it kind of falls down a little bit. And I don't know what's the best way of managing it apart from giving lower doses. But then that takes away the therapeutic potential to some extent. I think that's been its only kind of downside, if you like.
Thank you, Vinod. I thought I'll take the next question with Dr. Alok. And Dr. Alok, when you talked about indication in psychosis, I thought you missed on one thing. How about using quetiapine as a molecule during substance abuse and psychosis, whether it's independent or as a comorbid presentation?
Okay. Coming to the substance abuse and psychosis, a lot of literature which has coming up recently about the use of quetiapine in substance use disorder, especially alcohol or cannabis or even opioid. It is used during the withdrawal period also, as it has a sedation effect, even it has an anxiolytic effect, and it helps to calm the person by giving hypnotic kind of a dose. One thing we need to understand about the substance use disorder, use of quetiapine in them, there is likelihood that these patients are more becoming dependent on quetiapine per se. Recently, there are certain literature which is coming up from Western world that many of the people are taking quetiapine on their own and asking for the increase of dose. Especially these people who are substance use disorder are usually having comorbid personality disorders per se, as Dr. Vinod was telling. And this drug is so randomly prescribed in Western world that potential of abuse should always be kept in mind.
Thanks for that, Alok. And I was also wondering, how about use of quetiapine in dementia plus or minus delirium? Would you prefer this molecule?
As we all know, all antipsychotics have a black box warning in use in dementia. Okay, quetiapine is not having any exception per se. But coming to the type of dementia, like Lewy body dementia or Parkinson's disease with dementia, where the drugs which are having a strong antipsychotic kind of a potential, like strong blocking of D2 receptor, which are more likely to cause EPS in these patients. So in these patients, quetiapine is considered to be one of the ideal drug in terms of Parkinson's dementia and Lewy body dementia per se. Even said so, the thing is that we need to look at aspiration pneumonia because these people are more likely to have dysphagia. QT prolongation can be seen, and there are some risk of increased cerebrovascular accidents, falls due to hypotension per se. Coming to delirium per se, uh, if there is a hyperactive kind of a delirium, okay, so hypoactive delirium, quetiapine, I don't think so we would like to prescribe because the patient is almost drowsy. We won't like to make him more drowsy, especially in a hyperactive kind of a delirium, like in withdrawal of substances or in a infection or meningitis. In those patients, this drug is found to be quite beneficial, uh, as as I told, it dissociates from the D2 receptors very fast. As the mechanism of action of the quetiapine is unique, fast dissociation is seen at a very low dose, and the dosage we need to consider is around 25 to 100 mg in this delirium and dementia patient. And to start with, we would like to advise our listeners that 12.5 is also good enough dose in terms of elderly population. The advantage is the T half is very low. The half life is around 6 hours, so that the drug is out of them, and there is an immediate release formulation which you need to consider while giving, rather than the XR formulation in these patients, because XR formulation will not give you drowsiness immediately. It will take a lot of time to build up the dose. Thank you.
Thank you, Alok. I thought I'll also check with you. Do you also prefer this molecule as a primary insomnia, not as a comorbid symptom of other illnesses, but just to say primary insomnia, do you prefer this molecule?
Yes, this is one of the molecule which can be considered for the patients with having primary insomnia because of its H1 blocking property and alpha-1 antagonistic property. It causes sedation at a very low dose of 25 mg till 100 mg. The advantage of using this drug is it reduces the REM sleep, it increases the stage 2 sleep, and it helps in restructuring of the sleep pattern, which is disturbed in most of the cases of anxiety and depressive disorder. The FDA doesn't approve its use in the primary insomnia, as the risk of metabolic syndrome takes a higher priority and potential abuse liability. The side effects when you use this molecule as a primary insomnia drug, hangover is commonly seen, and some of the patients do complain about akathisia, and even few cases of restless leg syndrome are being noted in these patients who are using it. Thank you.
Thank you, Lok. Dr. Supriya, back to you again. So you have to unmute yourself. Yeah. Without asking anybody about side effects, Dr. Lok, Dr. Vinod has been talking about some side effects. So I know quetiapine has not been a saint. So theoretically, you have a lot of side effects. So vis-a-vis what actually happens in practice is what I want to know. So what are the common side effects that you encounter using this molecule?
The common tolerable side effects, usually some patients complain of dizziness, somnolence, dry mouth, constipation. Elderly population, I've had unfortunately patients who've had urinary retention. So we have had to go and stop the molecule for a few days, and the patient was catheterized. Then had a fight with the two gastroenterologists because one person said the quetiapine caused pancreatitis in his patient. And then it is not there in our common indications, but if you go low down the list, it is there. And then a patient had to undergo surgery for intestinal obstruction. So, I mean, they were not able to find any other cause. So they are blaming it on our drugs. But the patient was also on clozapine. So then it was on clozapine and quetiapine, but it is known to cause. But these are the unusual side effects which you don't encounter every day. The most common side effects will be more of anticholinergic side effects. Some patients, like Dr. Alok was saying, battling with sedation in the morning, hangover kind of effect. Then how Dr. Vinod was speaking about, even hyperprolactinemia is known, but not so much as it is with risperidone and amisulpiride. Um, a weight gain. So sometimes, like Dr. Vinod was saying, it could be used. The side effect could be used as an effect, in patients who are not eating well. But women sometimes, they'll say that I've put on so much weight, it is because of your drug. But these are the common side effects that are commonly encountered.
Thank you. But it's not so scary as we read in literature. Is that reassuring? Is that the message that the listeners should carry?
Yeah, it's actually the most common side effects are much, I mean, they doesn't really result in a dropout. It is not like a, uh, severe side effect of, extrapyramidal symptoms or, dystonia, which can happen with other more potent, like haloperidol and things like that. So, but patients do report, and then sometimes certain small adjustments in the way the dosage is given, like try to shift the dose to the night, shift from a IR preparation to a extended release preparation, slightly reduce the dose, ask them to take the dose earlier during the day. These small things can actually help improve the side effect profile, and eventually many a times these are self-limiting side effects. It's not that they're going to be there forever. So patients often get used to and then stop reporting these side effects. They tend to wane off, some of them.
Okay, thank you, Supriya. You and Dr. Alok kept talking about black box. So, what is this black box and how black is it? Is what I thought I should check with you.
So shall I take this up?
Yeah, I think it's your question.
Yeah. So the black box warnings are usually given by FDA to scare you from prescribing a drug, uh, like just for all the patients and without really thinking about the indication. So Dr. Alok also said, and even I had spoken earlier, that if there is an elderly patient with dementia, you wouldn't give quetiapine without, keeping a watch for things such as oversedation or aspiration pneumonia or fall, fracture, and then mortality. So all these things we need to really look at. So there is a black box warning against many antipsychotics, including quetiapine, for patients who are elderly, who may be prone to dementias, cardiovascular problems. Also, in patients who are on a child and adolescent who are on antidepressants and you're giving an adjunct quetiapine, even then you need to be careful because it can worsen suicidality. So these are the kind of literature that we come across.
So the black
As
box warning is a bit of a blanket kind of legal cover FDA has got, because there's a black box warning against all antidepressants, increasing suicidality. I mean, if that's the case, physicians are all not even aware; they're just prescribing it everywhere. But what do you say?
most of the times it's akathisia which causes the suicidality. So that fluoxetine black box, most of the time say when we are escalating the dose, the akathisia can cause the patient to get restless and suicidal. I think it's more related to that.
I thought I'll just take a question here, which could go on from Dr. Vinod, Dr. Alok, and then to you back again. We all keep talking about polypharmacy and combining quetiapine with so many molecules. So I thought each one of you could take one indication, mood stabilizer, combining with one more antipsychotic, combining with antidepressants or benzodiazepine. So you could go the way you want, and each one of you could explain one scenario where you could actually combine this in a polypharmacy sort of scenario. Dr. Vinod, if you could begin.
Yeah, so clearly for bipolar depression, which is a very common kind of presentation in our setup. I don't know for what reason, more than type 1. You get bipolar depression quite a lot. At least I get in my practice, and you have to. I mean, without thinking nowadays, if there's a clear history of it, then quetiapine and lamotrigine just go in. It does work quite well. So those two in combination, and then obviously if there's a propensity for sort of hypomania mania as well, lithium comes in, and then then the person stabilized on it, and then slowly there'll be like creeping up of depression. Then like, whoa, what am I going to do now? Increase the quetiapine a little bit, and then see how it goes. Maybe sometimes I would go with 5 mg of escitalopram just for a short period and then take it off again, So just playing around like that in bipolarity. Obviously, we have to do polypharmacy and tailor-made kind of cocktails for an individual person, what works for them. And that comes with trial and error and so on. Prescribing antipsychotics per se and quetiapine for people with personality disorders, the neurotic spectrum of anxiety disorders is absolutely essential. By the time it comes to us, after sort of the initial trials. So, we are going to give low dose of antipsychotics for the severe end of clients in the neurotic spectrum. Then, quetiapine fits in quite well because of its favorable side effect profile and used wisely for sedation at sleep and so on. I think those are the scenarios in which I would be combining lots of molecules, but as judiciously and as appropriately, and the lowest possible dose to start off with, and then escalate on clinical kind of observation and so on. Same principles, but we have to do it, don't we? So.
Thank you, Dr. Alok.
Coming to the polypharmacy usage of quetiapine with other molecule, unipolar depression. FDA has approved this molecule as an adjunctive to SSRI and SNRI. We need to understand that this drug in the range below 300, around 100 to 200 mg, up to 300 mg, is found to be beneficial in terms of antidepressant, as it has a partial agonistic action and FAST1A receptor, and the active metabolite of this drug, which is not quetiapine, which is having a lot good antidepressant property by acting on FAST1A, NED, and then FAST2C antagonistic property, with which there is a good amount of evidence as per the Maudsley guidelines, and they do say that it is better than lithium and antidepressant combination. This is one. And the second, in bipolar depression or bipolar disorder, where you want to use quetiapine, combination of lithium and quetiapine, we need to be a bit careful, because quetiapine per se, it reduces around 20% of T4 levels. The TSH alterations are not commonly seen with quetiapine per se, but in combination with lithium and quetiapine, we need to watch for thyroid profile. If it is seen, we need to correct it accordingly. Thank you.
Thank you, Alok. There's also one question from audience. I thought you could take it. How watchful we should be about use of quetiapine with cardiac illness? Is QTC a major issue with quetiapine?
QTC prolongation is seen with quetiapine. There is no doubt about it. But if it is in combination with some other drugs like quinidine, amiodarone, and those things, which are more likely to increase the QTC interval, this combination with quetiapine is much more harmful. It is not that worse as haloperidol. Haloperidol is more likely to cause QTC prolongation if we are using in delirium or dementia patients, which is the primary indication for low-dose haloperidol. We can use this drug, but baseline ECG is must, and we need to observe for any kind of tachycardia, hypotension, and regular ECG monitoring is required. Thank you.
When you say regular, how regular do you want it to be? How frequently should we monitor these ECG parameters? Every time we are a dose, or once we reach the target dose, should we recheck once in 6 months? What is your recommendation?
Initially, baseline ECG is mandatory, because if there is a slightest amount of QTC interval prolongation, there is no role of quetiapine at all. Then every week for at least a month or two, then monthly ones, or if you have some symptomatic observation.
Okay, thank you, Alok. Back to Supriya. I think you have to unmute. Yeah, we are back to the same polypharmacy and combination. So could you help us understand how comfortable it is to combine with other medications that we commonly use in psychiatry?
So if you look at a case scenario of a bipolar disorder patient in an acutely manic episode, though they are saying you can use quetiapine singularly as monotherapy, but what we normally see is the patient is on a full dose of a mood stabilizer, full dose of another antipsychotic, say risperidone, 4 milligrams BD, still not sleeping at night with a benzodiazepine added on. And quetiapine helps it definitely helps because, and another 100 milligrams of quetiapine at night will help patients sleep the night. So it helps in patients who are in acutely manic episode. Also in patients, certain patients who are prone for benzodiazepine dependence. Instead of, sometimes I've given them zolpidem, and then that has not been enough. Just adding a 25 milligrams of quetiapine has been enough to tide over that insomnia crisis, which may be brought about by some adjustmental issues. Then even in acutely psychotic individuals who are on a full dose of some other, like say risperidone or haloperidol, adding a quetiapine helps in the sedation part. So you can actually skip a benzodiazepine by adding a quetiapine.
So Priya, there's also one question that came from the audience. They wanted to understand. We keep talking about antidepressant or SSRI-induced suicidal risk, and black box warning is what we kept discussing. So, what's the role of quetiapine in suicidality? How comfortable you would be to prescribe this?
Quetiapine per se for suicidality as a indication, I wouldn't prefer quetiapine. It depends on the diagnosis per se. Where does suicidality come from? If it is part of a depressive episode, then I would like to treat with an antidepressant per se and add quetiapine as an adjunct. It is it is approved, but not for suicidality per se, as an augmenting agent. Then if it is in the case of a personality disorder, most of the times I think what works best is a antidepressant and a mood stabilizer combination. Lithium would probably work better on suicidality, but quetiapine can be given not for that primary indication. In my experience, actually, I haven't tried quetiapine as for suicidality per se in a patient who reports that as a symptom.
Okay, thank you so much for that. Back to Vinod. You think that this molecule is understated, underused antipsychotic? What's your understanding of this molecule?
Yeah, most definitely. And I remember having conversations with the sort of representatives in UK when it first came into the scene. That clearly they would argue that why aren't people using it as a first line? So, like you see an acutely psychotic person, the go-to molecule used to be risperidone. It still is. And if you see an acutely manic individual, you go for olanzapine. And only quetiapine would come in as a third, fourth line, and it's sort of, it's if you gave each molecule a personality, it is that kind of a character. That's the character of the molecule. It is not the first to go kind of person. I think in most people's practice, I mean, people can sort of clarify that if they wish, but at least my perception is that it is not everybody's to go first choice antipsychotic molecule. And I think marketing wise, they got it wrong, at least in the West. When it first came out, they hadn't worked out the SR formulation. I think for at least a couple of years or more, it was only available as an instant release formulation. And then if you're giving it in the morning, you're not adequately able to reach the dosage that is required for the antipsychotic efficacy as you would get with risperidone on or 3-4 milligrams even. So that's where it kind of lost out on the battle. But I think clearly what emerged over the years is, so I remember there was this really mega conference in London, and it was all about hyperprolactinemia, and quetiapine was being really touted as the answer to that sort of evil underlying thing which we induce in people and which leads to osteoporosis in the long run and so on. So it kind of wins over the commonly used antipsychotics when it comes to hyperprolactinemia. It's probably there under 10%, if that. I never even bother to check or worry about hyperprolactinemia when I'm prescribing quetiapine. EPSCs as well. It's not a worry at all. I think the anticholinergic side effects and constipation. So I wanted to ask, it's a there's this molecule called as Consti-Calo. I don't know what the exact what do we use that for, Mahesh? But is that useful when there is quetiapine induced constipation? I think it is. I've used it recently in about at least 3 or 4 people, and with good results actually. So that's very much useful in clozapine induced constipation. So I figured then, theoretically it's the same sort of mechanism that's leading to the constipation, so it might help. It does help actually, yeah.
Thank you, Dr. Vinod. Dr. Alok, we've been talking about different indications. So how about using quetiapine for depression per se as a primary indication? What's your take on that?
As I told you earlier, as a monotherapy for depression, it has not been approved by FDA. They tried to push, as Dr. Vinod was telling, in Western world, AstraZeneca was very much behind for the approval for the monotherapy of depression. A lot of pharma-sponsored studies were been done. There are a lot of lawsuits which are filed against AstraZeneca, and they are still going on. But yes, FDA approves it as an adjunct to any SSRI and SNRI. One thing is fluoxamine. Fluoxamine and quetiapine combination sometimes doesn't go hand in hand because of the sedation potential and the way it is metabolized. The quetiapine is metabolized by 3A4, and even the fluoxamine do so. It is an inhibitor, and the level of quetiapine increases, and hence sedation is very significantly high. About the dosing and depression per se, 300 and 600 milligrams were compared with each other in terms of outcome of depression as an augmenting agent. There was no added benefit beyond 300 milligrams as used in depression. Yes, in psychotic depression, small open studies have shown it is beneficial as an augmentation to SSRI and SNRI. Thank you.
Thank you, Alok. Any indications like grief along with depression? Is there any studies or is there any personal experience of use of this molecule in grief?
In a grief reaction per se, the depressive symptoms are seen during the grief period. For the sedation thing, we can use as a drug up to 25 to 50 mg. As in monotherapy of an depression in a grief reaction, probably I would like to be more skeptical. I have not come across such studies as an indication per se in a grief reaction. If the depression is very worrisome, SSRIs will be the first thing to be used, along with initial period of benzodiazepines to calm them up. If the benzodiazepine dose is required more, then adding quetiapine will help as an hypnotic. Like we say that it is a baby beer at 50 milligrams dose. It has H1 and alpha-1 blocking property. As such, you can use it, but with caution.
Thank you, Alok. Supriya, this is about rapid cycling. So what's your take on prescribing this molecule when somebody is rapidly cycling?
Rapid cycling is actually one of the scariest parts of bipolar illness, where a patient will have more than 4 episodes per year. Most of the times we make do with sodium valproate after checking the thyroid profile, substance abuse, any other causes of rapid cycling. But quetiapine as a add-on you can give, but monotherapy, I think one might burn their fingers because it will require more than just quetiapine to settle a rapid cycler.
It's a difficult question, but I thought any personal experience with this molecule in LGBTQ population?
Actually, in the last couple of years, like over the last 3 to 5 years, more and more patients with LGBT are coming forward and speaking to the psychiatrist. Many of them have gender dysphoria, but some of them have other illnesses such as bipolar and personality disorders. So quetiapine I have not used as monotherapy, but I have used in combination with a mood stabilizer, and it works well. It also works with an antidepressants. I usually prefer other antipsychotics, but with a mood stabilizer, it goes well. I've given it to a few patients who are from the LGBT community, mostly given for sedation rather than controlling aggression or agitation.
Thank you, Dr. Supriya. The audience need to put in the question in Q&A. Dr. Vijay, you need to help me out with the questions that's coming. I was unable to read through in the Q&A. So if you can WhatsApp the questions, the technical team or Dr. Vijay to help me out with some questions. I thought I'll go back to Dr. Vinod and ask him about one interesting case that he will not forget when he's actually used this molecule for a excellent or a wow experience with this molecule. Some patient that you would want to recollect, and for the listeners to understand how good this molecule was.
So I think yeah, it's a bipolar patient, and there was an issue all round. With she's about 65 now. 60 when I started seeing her, she was 63, and lithium led to nephrotoxicity, creatinine going up. So we had to sort of abandon that experiment completely. Sodium valproate gave her severe side effects, severe hair loss, and liver functions going disarray and so on. So and the whole family was really distressed by her kind of manic episodes, and she was switching also quite rapidly, because I think for years the condition hadn't been sort of managed well for whatever reasons. They were not seeking the right help, they were going down the spiritual path and all that nonsense. But finally she's so settled for the last at least 6 months now, more, maybe up to 9 months, on quetiapine, total of 300, so 200 SR at night and 100 mg, and along with lamocin. So lamocin 75 BD and that, and she's just spot on. The family are very grateful. They're from Coimbatore, and they forever kind of keep referring new patients and so on, that this doctor knows how to sort bipolarity out, sort of a thing. And so I mean that kind of comes to my mind, because I think the side effect profile is very favorable compared to other molecules, and we can use it, the side effects of the sedation in a very useful way as well, and for lots of patients I can think of, it has had a wonderful anxiolytic effect. Low dose, sort of just messing about with 25, 50, touching on 100 maybe, but that the anxiolytic effect is really helpful. So I've always held that this molecule, although started its journey as an antipsychotic, it ends up an anti-neurotic kind of warrior, and that it just works very well that way. Somewhere the molecules dosing trials were messed up. Somewhere, it was just one of those pharmacokinetic things they got wrong, AstraZeneca, and that's where they lost the battle of antipsychotic war. But I think they won in every other aspect, it looks like.
Thank you, Vinod. Dr. Alok, an interesting case that you would want to tell the listeners today?
One of the interesting case which I would like to share, around a year back, a patient was admitted around 30-35 years old, alcoholic. He was dependent on alcohol, repeated admissions at a rehab, but very poor in drug compliance, and repeated relapses were seen. We admitted the patient, detoxified him, and as a sedative, we started initially with quetiapine. That was almost a year or so back. We started with 25 mg, gradually upscaled it to 50 mg. Then we went up to 200 mg to 300 mg. Now, since 1 year, he's on only quetiapine 200 mg, maintained, doesn't have any relapse, and doing well. This aspect, which I feel all the listeners can take home, that this quetiapine in a lower dose, it is more of 5-HT receptor antagonist. Because of that, 5-HT2A receptor per se, because of that, dopamine starts pumping into the synapse. The D2 action is not that much significantly high, the D2 blockade. So it helps as an antidepressants and a bit of mood stabilizer, probably in this case, and as a sedative per se. Probably he does have some amount of personality issues, of a bit of impulsivity, a bit of cluster B traits here and there. But he's very happy with 200 mg of quetiapine, maintaining well. I think we can think of starting quetiapine and trying to manage such patients in substance use disorder. Thank you.
Thank you,
I
Dr.
I would just like to add to that. I think because of the anxiolytic effect, see, a lot of alcoholics go down that slippery slope because of unmanaged anxiety, and they get their anti-anxiety dosage with the drink. Like so if you've taken care of that, then there is not so much. And also, a lot of them drink to sleep well at night, so it takes care of both of those issues. So I think it's a very useful molecule that way, if you think about it practically.
Now I'm having a confusion whether he is dependent on quetiapine or we need to taper it or not. We don't know how the things are going, but the family is happy, patient is happy, he is doing well.
Safer dependence.
True, rightly said.
Dr. Supriya, your call on an important patient that you would like to recollect.
I've had a couple of pregnant women who have, before planning their pregnancy, they were on mood stabilizers. And then we were lucky enough to taper off the mood stabilizer and put the patient on quetiapine. Not 100, 200, but minimum 400 to 600 was required in these bipolar patients in remission. No mood stabilizer, only this antipsychotic monotherapy, smooth pregnancy, not much of problems. Post-delivery, somehow some of them were more sedated than they were during pregnancy, and but managed smoothly in the postpartum period also. And luckily, they've had episodes only 1 or 2 years after delivery. So very good molecule. One of the molecules to consider if you have patients who are pregnant or planning pregnancy.
Okay, I thought I'll just check with all three of you on different properties of this molecule. If you could rate this molecule on a 10 parameter scale, as an antipsychotic, Vinod, how would you rate this molecule?
I would say 4 out of 10. 10 being the best.
10 being the best. This is 4, is it? Okay. What about Dr. Alok?
Sir, I would like to rate a bit higher, around 6. But for positive symptoms, it's not good as compared to olanzapine and risperidone. It is akin to that, but better than your ziprasidone and something like that, Sertindole.
Thank you, Dr. Alok.
Elderly psychosis 7, but younger psychotic agitated 4.
Okay, so there seems to be some concurrence between Vinod and Supriya on getting 4. I thought only Vinod was
5, so
We've had very severely agitated psychotic patients.
I thought Vinod was really giving a lower score, being miserly, but now I can't say that since
so my rating, if you ask about kind of his place in managing anxiety-based disorders, personality disorders, the neurotic spectrum, I would give it a 7-8. I think so. That's what I meant when because I think it can work as an antipsychotic. It's just the dosage. We can't get up there. And tolerability becomes an issue. That's the problem.
Okay, thank you, Vinod. Since you started the thread on use on other indication, neurotic spectrum disorders, you say 7 or 8 on 10. So what about Alok on these indications?
I completely agree with Dr. Vinod. Obviously, it has a very good anti-anxiety drug and antidepressant. But as a monotherapy, I'm a bit skeptical. But as an add-on, surely it is better.
What's your
The
score?
anxiety spectrum.
Around 7, sir.
7. Thank you. Yes, Supriya.
I'll go with a 7 too, but more so with patients who are depressed and anxious and bipolar depression. But other things like GAD, OCD, grief, I wouldn't be able to rely on quetiapine as a monotherapy, but as an add-on. 7.
Yeah, thank you.
In PTSD, some of the studies are done on quetiapine, which I have come across. It helps in hyperarousal and flashbacks in much more better way.
Thank you, Alok. I thought I'll just check on the same pattern of scoring for mood stabilizing properties of quetiapine. Yes, Vinod.
I would say 6, 5, 6. I wouldn't trust it on its own so much, So it going in with lamotrigine, I'm happier. It going in with valproate, I'm happier. But somehow it depends on the client, I suppose, But I don't have a lot of experience of it being a good mood stabilizer as a monotherapy.
Score. Vinod, I want your score.
Oh, I said 5, 6, maybe 5.5.
Yes, Alok.
Sir, if you divide this bipolar spectrum, bipolar depression, I would like to score it very high, around 8 or 9, if the patient tolerates the drug well. With the augmentation of lithium and along with valproate, it stands very good. As an anti-manic agent, don't feel that that is so good. I go with Dr. Vinod, around 5. As a bipolar depression, 7 to 8. As an anti-manic agent, 5.
Thank you, Alok. Yes, Supriya.
Bipolar 2, same as Dr. Alok, maybe slightly higher, 8 to 9. And bipolar 1 patient, around 5 to 6.
Okay, so there seems to be some consensus without actually discussing about this molecule in that way. The rating seems to be going in consensus. So I thought I'll just give you one more exercise. If I were to ask you to take the role of marketing executive for marketing this drug, I want Vinod to sell this drug in 1 minute's time.
Oh, my time starts now. Yeah. Good morning, doctor. I'm so happy that you gave me some time today. I know you're very busy, so I'm not going to take too much of your time. I represent AstraZeneca, and we've got this wonderful new molecule. There's a lot of data. I'm just going to leave some information for you to browse through because I'm sure you can look at it and understand it better. But I can assure you that this molecule will enhance your practice, particularly when it comes to helping patients with anxiety-based disorders and add-on therapy in depression. Very useful for people who are having difficulties with sleep, particularly, and who also have aggression. Definitely lower doses for that. You can use it with your eyes closed in bipolar depression. As you know from the studies, that is only one of the 2 really big molecules in that area, and it's got its own advantages as well because of its sort of side effect profile. It's a very, very competent molecules, and it will enhance your practice. I would say that, looking at a typical practice, if you purely look at it from volumes perspective, it will help you with more of your patients. So the number of psychotic patients you see will be less than the number of people who have other issues. So, my molecule will be prescribed by you, hopefully, sir, more often than its immediate competitors. So if I can be of any other help, sir, do let me know. I can assist you with more information, sir.
Thank you, Dr. Vinod. That's wonderful. Yes, Alok.
I can't match up with Vinod, sir. Yes, if I'm a representative who wants to sell this molecule, I would like to say to all the clinicians that if you are in a confusion, if you don't know the diagnosis per se, this is a drug which is an all-rounder. At 50 mg, it is a hypnotic, sedative, anxiolytic. At around 300 mg, a robust mood stabilizer, and most importantly, antidepressant. And if you go higher down, 400 to 800 mg, it is an excellent kind of a antipsychotic drug with good amount of sedation. Many of the patients in the clinics which you get, they complain that they don't have sleep properly. This drug is alone to give them good amount of sleep, and side effect profile are very favorable. If you compare with the other molecules like olanzapine or clozapine, the weight gain profile or metabolic side effects are very limited, very less, and you can surely consider this as a first option. If you consider typical antipsychotics like haloperidol, this is the molecule which doesn't cause any amount of EPS, and you need not add any kind of an anticholinergic to this because as clozapine is there, quetiapine is also belonging to that category. Don't need any anticholinergic. So I feel any confusion, go ahead with quetiapine.
Thank you, Alok. That's wonderful again. Supriya, sorry to keep you waiting. I know.
Yes, I was thinking of new state strategies now.
I thought the lady rep should be seen first. She has to go attend to the family and kitchen. Sorry to keep you waiting. Now you can go ahead.
So I'm thinking of a scenario in which the doctor is very busy and does not have much time to read literature. So I'll say that, sir, if there is elderly patient with sedation, give quetiapine. Half tablet of 25 will do. If there is a or slightly older patient with substance abuse, lorazepam 2 mg not working, give quetiapine 50 mg will definitely work. If there is a manic patient not settling with bipolar, with just 1 gram of valproate, add quetiapine at 100 to 200, maybe 400 milligrams will work. If there is an anti-psych person who you don't like risperidone for EPS, try quetiapine at least, but 400 to 600 you will require, it will work. And the size of our molecule is slightly smaller, and we have slashed the cost, so it will work.
I'll definitely prescribe after this,
So I was just trying to sum up this molecule for people who are listening. So I think this is the best way to understand how this molecule could be used. We are coming to the end of program. I hope we were able to convince our viewers to give the confidence to prescribe this molecule across the indications. Quetiapine is known to be a good antipsychotic, a good mood stabilizer, good anxiolytic. Across the indications, across neurotic spectrum, people have used it, including OCD people have used it. There's so many reports. So it will not be wrong for us to state this and say that this is an all-rounder molecule. We could place it in so many spectrum across the psychotic versus neurotic spectrums, across the population, from the younger group to the elderly group, across medical disorders, even with having metabolic impairments and renal or hepatic impairments. This molecule has found to be quite useful. And we know when to prescribe. All of us are masters in that. How safe this molecule is, what you're trying to look at it, and just look at prescription patterns. And Dr. Vinod gave us insights about how useful this molecule is in UK versus India. So I think there are a lot of insights that we discussed in the last 1 hour. I try to just keep it lively and more interactive and a lot of questions, so there's no slides for presentation. I hope the audience like this scenario. Thank you everybody for giving me this opportunity. I thank Dr. Jagdish, for whom I was stepping in. If he was there, I wouldn't have got this opportunity to rag all three of you today. Thank you so much. Over to Dr. Vijay.
Yeah, Mahesh, you've done really well. You kept all the the audience on the feet, and I'm sure there were 130 plus audience, and enjoyed the show, and it was very informative, very useful, I guess. And this molecule quetiapine as an all-rounder is definitely based on what the discussion. I think it is an all-rounder. At least in 2 cases where valproate had caused drowsiness, and then we found out it had severe, significant ammonia, increased ammonia levels. I had to call up Dr. Jagdish and see, sir, what do you do in these cases? Try quetiapine as a mood stabilizer. And this is what I've done actually, and it worked. So in many other cases also it has worked, especially the psychosis in Parkinson's, what Dr. Alok was mentioning. I've used, and in my literature review, in my thesis, this has been highlighted after clozapine, of course, but clozapine has its own limitation. Again, in my geriatric psychiatry in implants also, we've used a lot of quetiapine. It has done a lot of wonders. Definitely, it's a molecule that is useful. Like it's a savior for clinicians, I'm sure. Anything from Inta's team want to quick summarize or quick say thank you or something?
So thank you so much. So thank you so much, and it has been very enlightening to us, and we are highly grateful to give to all of you, sir, providing us an opportunity, and proper understanding of this molecule has been very significant. Particularly me and Ankit, I think we have been enlightened about this molecule as such that we never had this knowledge before, and every nitty-gritty of this molecule has been I am able to understand, and the usage I am able to understand. So it would very much useful for us and our marketing team as well. So thank you so much. And for any other educational platforms, so we are always there in support. Thank you, ma'am. Thank you, sirs.
Yeah.
Dr. Vijay, I had a feedback. We tried this 1 minute extempore discussion on a topic of their comfort. Probably we should generate a competition to send video recordings of 1 to 2 minutes to select the best speaker who can actually talk about a very neutral, insignificant topic, just to emphasize on presentation, emphasize on communication skills, and actually have a prize for it. 1 to 2 minutes video is what we can plan.
Yeah, I'm sure. Yeah, thank you, Intas team, for hosting this. I would say thank you very much, all the audience. Because of you, we're able to conduct this program, and this is a good turnover all over India. Thank you very much. You've been there. Because of you, we're able to conduct this program. So, and then in line, I have to thank Dr. Supriya, Dr. Alok, and Dr. Vinod for taking time out and coming out and giving this wonderful talk and made it lively. Dr. Mahesh, you really did very well, and I'm sure Dr. Jagdish would be happy that you did fill him in his shoes, and you did well. Thank you very much, everyone.
Thank you.
Shubhratri, good night. Good night. ಎಲ್ಲರೂ
Night.
Thank you.
ನಿದ್ದೆ
Happy
ಮಾಡ್ರಿ ಎಲ್ಲರೂ.
Thank you